Hello, my name is Michael Lenia, and this is the relationship between OSA and asthma in the adult population. So to start off, asthma and OSA have been long thought to share a connection, and this has been studied through various means and methods, but an established relationship has yet to prove the cohesive nature of both diseases and how they share that. So what is the missing link between asthma and OSA? And how are they connected? Are they to a degree influenced by disease severity, or are they singularly unique symptomatically? So the focus of this study is to investigate and confirm a connection between asthma and OSA through the collection of retrospective data and research. So what is asthma? Asthma is a lifelong inflammatory disease mediated by changes related to inspiration and expiration associated with the upper and lower airways. So what this means is as somebody with asthma breathes in, the bronchial tubes become constricted and inflamed, and this can lead to tightening of the airways. This can pervade into the daytime and the nighttime. So many people who suffer from asthma experience symptoms throughout the day and at night. There are various degrees of severity encompassed by genetic predisposition, environmental, and structural factors. What is obstructive sleep apnea? So on the other end of things, obstructive sleep apnea is a form of sleep-disordered breathing that revolves around many mechanisms involving airway obstruction. It typically involves upper airways, and this could be for a structural reason, or it could be related to hormone levels, weight, biologic factors, and what happens is that person or individual experiences episodic air loss followed by recovery. And usually an indicator of obstructive sleep apnea is habitual snoring. Explaining relevancy. So asthma was found to have a higher frequency in those with OSA. However, this was just one end of the bidirectional relationship. Inversely, they weren't sure if OSA was more frequent in an asthmatic population. So this is one area that needs investigation. Higher occurrences of both diseases were found to be more frequent in males within older age groups, and to add to that, males also experienced their symptoms more, like they were a little more severe than females. CPAP treatment showed improvements in asthmatic symptoms, suggesting treatment plausibility for both diseases. There were some minor changes in airways and some improvements in, as I said, symptoms. However, there wasn't enough evidence that showed long-term changes in the airways, and those who did improve with CPAP treatment only tended to have mild to moderate asthma without exacerbations. Asthma and OSA negatively impact sleep quality and quantity. So typically patients with asthma and OSA have experienced less deep sleep. So this would be your N3. And they also experience less REM or delays in REM onset. GERD may affect, which is gastroesophageal reflux disease may explain symptomatic crossover through shared mediation, and this would suggest a tridirectional relationship instead, because GERD has that inflammatory marker that's very similar and affects those airways, especially at night. It was proposed that GERD could possibly be a link between asthma and OSA, or at least share some symptomology with both of them. What to consider? So CPAP treatment effectiveness is dependent on asthma severity. And what that means is it's viable for only those with mild to moderate disease, like I mentioned before. And there's a lack of evidence for structural changes. So lack of investigation into the possibility of an inverse relationship, OSA prevalence in those with asthma. Other diseases may account or contribute to shared symptomology, so this would suggest a higher degree of comorbid complexity. And this could be accounted for by GERD or other diseases like COPD. So the study. I collected patient data via retrospective chart review from UNC hospitals. The data was purely aggregate, and it was mainly on age and gender. There was no personal information obtained. It was really a general consensus of population data from the UNC hospital system. I used ICD-9 and 10 codes for diagnostic purposes. The data sets and queries for populations were created using UNC's I2B2 database, and this allowed me to create certain sets for data and gather my groupings and populations so I could test each one. I had two groups, and these were used for comparison. So group 1 was the males 18 to 54 with asthma at UNC hospitals, and group 2 was females 18 to 54 with asthma at UNC hospitals. Data analysis. So the data sets and queries were pulled and contained numeric results. I had male patients with asthma, male patients with asthma and OSA, male patients with asthma, OSA, and GERD, female patients with asthma, female patients with asthma and OSA, and female patients with asthma, OSA, and GERD. So what I initially did was I took the male patients with asthma and the female patients with asthma, and that was my base population, my control. And I took that population and used OSA as a diagnosis to see how many people within the asthma population also had OSA. And then I took that population and threw in a diagnosis of GERD in order to figure out whether there were higher incidences of all three associated together, or that if GERD made a difference in frequency and incidence. So here is my first chart. This was my general asthma population. So I thought it was interesting that those diagnosed with asthma were more common in the 18 to 34 group, and it actually appeared that it was more consistent across all the other age groups as they got older, maybe a little higher in those in the older age groups, but not nearly as high as the younger group. For my second and third charts, I took that same population and included a diagnosis of OSA to see how many people in the asthma population would also have OSA. So the data looks drastically different. It's more of an upwards trend. So those with asthma and OSA had higher rates in older populations versus younger populations. And I also threw in a diagnosis of GERD for chart 3 in that asthma and OSA population. And it appeared to have a similar trend with the 18 to 34 population having the least amount of diagnoses or comorbidities, and with the frequency increasing as age increased. So my results. So I found OSA does not appear to have a high prevalence in the asthma population. Asthma was more commonly diagnosed in the younger population and was associated with an age-related downwards trend. I say it kind of had an age-related downwards trend to an extent, although it was a little bit higher in the latter age groups, but not nearly as high in the 18 to 34 group. So it was more probably even across the latter age groups, with some minor differences. The opposite was the case for the comorbid populations who were associated with upwards trends among age-related diagnoses. So as you get older, comorbidity increases and you're more likely to be diagnosed with both. But one thing to note is that OSA did not appear to be frequently common in those with previously diagnosed asthma. Females had higher rates of disease in all groups except accounted marginal differences noted in the 18 to 34 group. So in the populations with asthma and OSA and asthma, OSA, and GERD, the males in the 18 to 34 group had a little bit more or a higher rate of comorbidity than females, but it was so marginal that it didn't make much of a difference. GERD was more frequent in those with comorbid asthma and OSA, with rates climbing to greater than 50% as age increase. So I thought this was interesting. GERD had a higher frequency, and it seemed to strengthen the connection between asthma and OSA, because the numbers didn't appear to be that much different from those with asthma and OSA. And I thought it was interesting that a lot of people out of the asthma and OSA group had all three. Discussion and conclusion. So the data provided was not inconclusive in regards to an established relationship between asthma and OSA. So it strengthened it a little bit, but it didn't really establish anything in regards to the relationship. If anything, it kind of proved the opposite to an extent, because OSA was not that frequent in the asthmatic population. So as I said, asthma and OSA have less of connection than once thought, so little support for the existence of an inverse relationship. So this goes back to the beginning where I explained that there was research into inverse relationships or investigation needed to be done in that, because apparently asthma is more frequent in the OSA population, but that might not necessarily be true for OSA being frequent in the asthma population, which according to the data that I found, it shows that OSA is less common in the asthmatic populations, or at least from what the population that I gathered. Gender differences in disease prevalence were stark in contrast to previous studies. So females had a way higher rate than I thought initially. I thought it was going to be males because of all of the previous studies that talked about how males had higher incidences, and especially those in the older age group. This did not appear to be the case. Females in the older age groups had the highest rates of diagnosis, especially with asthma and OSA and asthma, OSA, and GERD. The inclusion of GERD provided more insight into the possible existence of a tertiary relationship. So there was definitely more support for this because the association with GERD climbed to over 50% as age increased. So more people from the asthma OSA population, as you got older, you were more likely to have all three. And future investigation research should take into account the impact of severity on comorbidity and the mechanisms shared between asthma, OSA, and GERD. I don't think there's enough research into severity that can drastically affect how the prevalence of OSA in the asthma population, and the same goes for GERD. And I think because of how prevalent GERD was in those with asthma and OSA, it's important to investigate possible factors and mechanisms that could make that more frequent and could possibly help strengthen that connection. And here are my references, and this is my presentation for the relationship between OSA and asthma in the adult population.